We change gears, coming now to the much awaited session on pediatric hepatology. We have 4 amazing speakers, experts lined up for you for this session on pediatric hepatology. For this session, I would like to invite on stage the honored chairpersons, Anshu Srivastava ma'am, Dr. Malti Satyasekaran, NP Bohidar sir, Dr. Priyanka Udawat, Dr. S. Arul Prakash, and Dr. S. K. Yacha sir. Can you grace the stage with your presence? Chairpersons, this session is yours.
Good afternoon, everybody. Now, after frailty, we'll have to come to pediatric population. And here we have the first speaker is Dr. Ava Nagral. Request Dr. Ava Nagral to kindly take to mic.
Dr. Ava Nagral is a hepatologist who is actually practicing in Mumbai and has a special interest in pediatrics, and you have all seen her mite yesterday, how she was felicitated by the American president of ASLD for frequently asked questions where she was the coordinator. So go on to Dr. Ava, your topic please.
Thank you, Dr. Yacha, and thank you to the organizers of the INASL Committee of Orissa. Fatty liver in a child has been increasingly diagnosed now. Is the metabolic syndrome in children different from adults? Is it NAFLD or an inborn error of metabolism is the question which we commonly face when we have a child with a fatty liver. And how far does one go to investigate a child with fatty liver? Now, as far as fatty liver in children is concerned, we know that NAFLD is the most common chronic liver disease across all ages, and the prevalence of NAFLD, I'm still using the term NAFLD if you note, because that's what literature said so far, is wide, not only up to 40-45% in obese children, but up to 20% of lean children, depending on where the data is from. Alcohol consumption is not a main contributor in children with fatty liver disease, and hence the pediatric societies thought that pediatric fatty liver disease is a more appropriate term rather than NAFLD. We've been hearing about the Day-3 consensus and the change in definitions which have been recently published in June, Journal of Hepatology. But the pediatricians in the Day-3 consensus were not keen to use the word MASLD, metabolic dysfunction associated steatotic liver disease, as they thought that the term metabolic here would confuse with inherited metabolic disorders. So it is still pediatric fatty liver disease as far as children are concerned. Now, why are children susceptible to fatty liver disease? What has been shown? Who are the children who are susceptible? It's those who are small for gestational age as well as those who are large for gestational age infants. Mothers who are obese and type 2 diabetics have a higher chance of children with fatty liver. A decreased microbiome diversity seen at 6 months of age has been shown to increase the risk of obesity by the age of 7 years. So thereby telling us that the microbiome is extremely important as far as pediatric fatty liver disease is concerned. Whether the child is breastfed or not also determines the colonization of the intestinal microbiome. and it has been shown that this is protective against fatty liver disease. Further, in animal studies in dogs and pups, it has been shown that high-fat diets in pregnancy in these animals results in a fatty liver in offspring. So these are the conditions which make one susceptible to pediatric fatty liver disease. So the question is, whom do we screen? All obese, that is more than 95% percentile, or overweight, more than 85% percentile for the weight, for the age, children who are equal to or more than 9 years. So if you have a child less than 9 years, you don't think of pediatric fatty liver disease. So 9 or more with a high BMI, overweight children who have a family history of fatty liver disease or presence of any of the cardiometabolic factors, and the society, the American Society suggests that ALT should be used as the initial screening test for NAFLD or pediatric fatty liver disease. So this is the last guideline which I could come across, the NASPGHAN 2017. I think with the new definitions for adults, we await those for children as well. So any overweight or obese child, 9 years or more, the screening test suggested is not an ultrasound but an ALT. If the ALT is high, then look for any specific causes, the common causes we would look for. If they are ruled out, then start thinking whether it could be fatty liver disease. If there are no symptoms and the child has an ALT which is less than 2 times upper limit of normal, then try diet and lifestyle modifications, repeat ALT. If it's improved, continue. If not, then investigate further. So what are these cardiometabolic factors which have been defined for pediatric fatty liver disease in this Delphi consensus? This was the only thing actually related to pediatrics which was mentioned in this consensus, and it's a little different from the many definitions of metabolic syndrome, but they say that if one of any 5 of these are positive, then this child should be investigated for fatty liver disease. So I'll not really read through this, you can take a picture, but basically it's looking at BMI and waist circumference. It's looking at fasting sugars, post-glucose sugar and HbA1c, blood pressure, triglycerides and HDL, like pretty much what you would in adults. But unlike adults, here most of the values are in percentiles, and I think this is important. What about non-invasive tests in evaluating pediatric fatty liver disease? VCTE has been validated in children, and a value of more than 9 kP is associated with advanced histological fibrosis in children. So this is one thing which has been validated, but again has not got into any of the guidelines. There has been a pediatric NAFLD fibrosis score which has been defined, but again it's based on ALT, alk-phos, platelet counts and GGT. It remains to be validated. So FibroScan and other blood tests have not yet been included in guidelines for pediatric fatty liver disease. So therefore, liver biopsy becomes very much important. Unlike in adults, in pediatric fatty liver disease, it's still important. It's used when diagnosis is unclear, when there's concern for multiple diagnosis, where the ALT remains high despite lifestyle modifications, and if you have a clinically suspected advanced liver disease when you're wanting to give any specific therapy. So when do you suspect advanced pediatric fatty liver disease? High ALT, splenomegaly, AST, ALT ratio more than 1, or if you have risk factors for NASH in children, which includes pan-hypopituitarism and type 2 diabetes. So any of these, one would go ahead and do a liver biopsy. Now, how is it different in children? This is the one in adult, type 1, where the inflammation is mainly around the central vein with Mallory's high-line steatosis and ballooning. We are all familiar with the NAFLD activity score. Whereas in children, the changes are mainly around the portal tract, and there is not much ballooning and Mallory high-line, and therefore this is even more difficult to kind of quantify with the NAS score, and it has some implications. This is the type 2 which is seen in children. So children can have both type 1 and 2. Their scores on NAS, NAFLD activity score, is lesser because they're not getting much on inflammation and ballooning, which is an important component of the score. And fibrosis is a much more reliable indicator of outcome. In fact, those who have portal disease have more advanced fibrosis and progressive disease. A little about macro and microvesicular fat. Macro one is familiar when you have the nucleus pushed to the side of the cell, whereas microvesicular is typically a bubbly cytoplasm with the nucleus in the center, each micron being less than a micron, and each bubble being less than micron in diameter. Microvesicular fat suggests inherited metabolic liver disease, whereas if it is there in a patient with NAFLD or pediatric fatty liver disease, it usually signifies a more severe disease. Again, in IEMs, basically it is either increased delivery of fat or fatty acids to the liver or reduced efflux from the liver, which causes this fat. Coming to management, now we know that most of these patients would be counseled against what is different, specific counseling for binge drinking, smoking or use of electronic nicotine or any form of tobacco, and this is especially important for adolescents because that's where also the fatty liver disease is common. Families of children with NAFLD should be counseled about risks of secondhand smoke exposure. These are the specific things we do for the families of children and ensure there is protection for hepatitis A and B. So these are very basic treatment options, specifically mentions sugar-sweetened beverages, healthy, well-balanced diet, exercise, and I think important is give less of screen time, which is becoming a major problem. No current medications have been approved, and other interventions in the form of bariatric surgery for select individuals with BMIs more than 35 and with one of the cardiometabolic problems or important risky diseases associated would be candidates for bariatric surgery, which would be older children or adolescents. So this, I thought I'll spend a minute on. Limit screen time. I think this is crucial for children today. Start with yourself. The parents need to lead by example. Engage kids in other activities which makes them use less screen time. Keep the gadgets out of reach, easier said than done, but especially you can start young and involve them in other activities. Meal time, family time, no screen time. Arrange for play dates, get them out of the house to various things for which the parents have to be available. Encourage hobbies, things which children are interested in, and encourage that. Talk to them about disadvantages. Enjoy a screen-free day. Monitor their online activities, again, easier said than done. And start small. Do not force them, simply just motivate. All these things I think are important more for us than for the children, but I thought it was important in at least emphasizing this for the children. So that's about pediatric fatty liver disease. Now, is it all just that, or is it something more? You could have drugs, you could have systemic disorders, and you could have inborn errors of metabolism also, which cause fatty liver in children. So coming to systemic causes, we know rapid loss of weight, TPN, other diseases like IBD, celiac disease, hepatitis C, nephrotic syndrome, etc. And certain endocrine problems can also cause a fatty liver. And then there's a whole list of drugs which have been associated with fatty liver. This is a very good article from Journal of Hepatology from Dr. Dhawan's group, where they talk about the various phenotypes with which inborn errors of metabolism can present. And one needs to look and think about fatty liver. And I will urge everybody to read this article. So you could have a fatty liver in an acute liver failure. So what are the differentials of that? I'm not reading through it, but just to tell you that see the phenotype. There are 5 phenotypes here described: acute liver failure, neonatal jaundice, organomegaly, psychomotor retardation, and an asymptomatic child. And each one has a differential of different diseases. So this will help you to limit your diagnostic tests to the phenotype which is common with fatty liver in this situation. So is it a simple NAFLD? You have a child with fatty liver, or is it an alternative etiology? Simple NAFLD or pediatric fatty liver disease, central adiposity, high BMI, male gender, Hispanics have much more fatty liver than the non-Hispanics, fatty history, family history, and sedentary lifestyle. Alternative etiology, if the child comes at a younger age, especially less than 5 years, there are no obvious risk factors. And if you have any of those clinical phenotypes, which I mentioned in the last slide, think of alternative etiologies. Now, just to give you a brief on what happens in inborn errors of metabolism and fatty liver. How do they develop fatty liver? So we know that when you have a patient with a fatty liver, it's either increased delivery of fatty acids, which could be acquired or inherited, and a reduced efflux of fatty acids. And this is the hepatocyte with the mitochondria. So you could have pretty much anything going wrong. The fatty acids get into the liver through the carnitine transporter, they get oxidized in the liver, and through the dehydrogenases, they get either going to the respiratory chain or the Krebs cycle. So anything going wrong along these pathways could cause fatty liver and related to the inborn error of metabolism. Again, from the same article, again, very good. Just to tell you, I'm not reading through this, but how different mechanisms are related to various diseases and at what site do they act in the hepatocyte and the mitochondria is very well explained and worth reading. You can get clues to the diagnosis of fatty liver depending on what the condition is. If it's galactosemia, you'll see cataracts, avoidance of sweets in HFI. Wilson's disease will have neurological symptoms, maybe a hemolytic anemia. A child with hypoglycemia and chubby cheeks could be a glycogen storage disorder. Wallmann's disease with adrenal calcification, and so on and so forth. So look for clues for fatty liver. And this is a table telling you that look at the age group. So if you have an infant, it's likely to be mitochondrial hepatopathy, urea cycle defects, etc. Children can have pretty much all these in all age groups, and adults usually will have either viral hepatitis, Wilson's disease, classic pediatric fatty liver disease, or celiac disease as cause of the fatty liver. You can have another condition called lysosomal acid lipase deficiency or cholesterol ester storage defect, which is seen typically in older individuals. In infants, it's called Wallmann's disease. And they have manifestations exactly like a pediatric fatty liver disease. So there's fatty liver, dyslipidemia, cirrhosis, and liver failure. So it's a rare disease with a common phenotype. They have, just my last slide. Accelerated atherosclerosis, and this has to be identified as different from the standard pediatric fatty liver disease, and it has a specific treatment now available. So to summarize, we do not treat any fatty liver as benign, look for other causes. Still, pediatric fatty liver disease is the most common disease in a child above the age of 9. If the child is less than 5 years, look for inborn errors of metabolism. But these can occur even in older children, and look for red flags in older children to identify these. And there are many treatable inborn errors of metabolism, like hereditary fructose intolerance. I'll not again read through these, but these need to be specifically looked at because there is a specific treatment available. And depending on the clinical phenotype, especially when you're suspecting an inborn error of metabolism, investigate only related to that phenotype to cut down the costs and time for getting to the diagnosis. Thank you.
Thank you, Dr. Abha, for that excellent exposition on pediatric fatty liver. Now I would like to call upon Professor, questions at the end. Thank you, Dr. Ibrahim. Yes. Professor Seema, she's the professor and HOD of hepatology in ILBS. I think you would have seen a lot of papers on pediatric hepatology from their department, and would like to ask her to speak on hepatitis C in children. Why should we treat? When should we treat? How should we treat? How long to treat? I think you'll cover all that. They've put it as treatment options, but I think you'll be covering. Thank you, Seema.
Thank you, everybody, and thank you, INASL, for giving me this opportunity to take up this topic. Okay. So what is the global prevalence of hepatitis C in children? And this was a modeling study which said that although we do see a prevalence of 0.13%, but we expect that it corresponds to 3.26 million children living in this world with HCV, and maybe half of these children are present in Pakistan, China, India, and Nigeria. And this was a logistic model study where they felt that India may have shown a very low prevalence, but actually, if you go into those logistic models, India may have a double of the prevalence that we are actually reporting. So it means that a lot of our children who are asymptomatic are not tested and are still remaining with HCV. And that may be showing in the adult population, where the adult population comes up with HCC. So natural history, as I told you, is a very mild necroinflammatory changes you'll find in majority of the children with chronic HCV. They're born with vertical transmission is a common transmission. They're born with HCV. Within 4 years, 20% of them may have a spontaneously clear their infection, but 80% of them will live with it and become cirrhotics in adulthood. The treatment of HCV before we had the direct acting antivirals come to this country was very different. We had just for genotype 1 and 4, the SVR12 was just about 48.6%. Abysmal number of patients could be cured or treated. Genotype 2 and 3, we're a little better off there with 90.9%, with a very high relapse of 6.1%, biological breakthrough of 3.4%, and treatment discontinuation because of various reasons was there in almost 17.7%. So we were doing very badly before the DAs came through. Now for the HCV virus, this is a Flaviviridae family discovered in 1989. The genome contains, has 3 structural proteins and 7 non-structural proteins are encoded by this genome. As you can see them on the slide there. 7 genotypes of HCV, genome 1 and 3 are the commonest ones, being 46 and 30% prevalence. Genotype 2, 4 and 6 have roughly approximately prevalence of 22.8%, and rest of them are very not that prevalent. 10 of these HCV proteins that we have just talked about have important roles to play in the viral life cycle, and hence they become potential drug targets to inhibit the HCV replication, which we will now see. This is a slide taken from a very good review that has been published in Indian Pediatrics by Dr. Podar, who's sitting there, from SGPGI. I would encourage you people to please go and read up this, because it's a very comprehensive review. So if you look at the structural proteins and non-structural proteins, the 3 types of direct acting antivirals which are available to us, the first one, that is the protease inhibitors, which end with Previr, are against the the non-structural protein 3 and non-structural protein 4A. And the only drug which I know is useful for children is the Glecaprevir. I will have this problem again and again. So Glecaprevir is the only drug that I know of from that group. As far as the NS5A inhibitors are concerned, which end with Asvir, we have a number of them which have been tested in children: Declatasivir, Ledetasivir, Velpatasivir, and Pibrentasivir. And the only one NS5 polymerase inhibitors can be divided into 2. They are either nucleoside inhibitors or they are non-nucleoside. And the nucleoside inhibitor that we are all aware of about is the sofosbuvir, which has been tested in children. So now I'll take you through how it was tested in children and what are the regimens which are now working. So if you ask me what happened with Ledipasvir and sofosbuvir, this was the first regimen which came through, and it was first tested in children between 12 to 14, or the adolescent age group, largely genotype 1 and 4. In these 4 or 5 large studies, 90 gram of Ledipasvir and 400 gram of sofosbuvir given OD for a 12-week period was the usual thing, except for one study which had 9 to 12 years of age group children. Otherwise, rest of them were all adolescent. And if you see this, the SVR2 was ranging from SVR12 was ranging from 98% to almost 100%. So it was a very good response that they saw with this regimen. And another study came with the same regimen with half the dosage given for another 12 weeks or so, and 99% was the SVR seen in this patient. Although this group had largely genotype 1, very small number of genotype 3 and 4. So Esfagan, when I say it's starting with the E, Esfagan came up with a positional paper on this, showing that the ledipivir and sofosbuvir regimen has a very good response, and they have a good, very low virological breakthrough and very low relapse as well. And they felt that this regimen can be used for children above 4 years of age in genotype 1 and 4, and also can be used, if you have compensated cirrhosis in those cases, then you have to, instead of giving for 12 weeks, you have to give it for 24 weeks. But for other genotypes like genotype 2 and genotype 3, they did not agree to allow this regimen alone to work, and they said sofosbuvir with ribavirin should be working in this age group. US and Europe at that time did not even agree to allow this regimen to come through, and they continued with peg interferon and ribavirin. So this was in 2018. Another study came around about 2020, which now looked up the role of ledipivir and sofosbuvir for 12 weeks in a phase 2 trial, open label in genotype 1, 3, 4, 5, 6. SCV, most of them were SCV treatment naive, some of them were experienced as well. Duration of 12 weeks was given for genotype 1, and for genotype 1 with cirrhosis, duration was taken to be 24 weeks. So this enrolled about 34 cases, and 34 cases in this, and again the SVR2 12 was very high, or almost 100%. So you can see it here, almost 97% SVR12 that we could see in this age group as well. So with this, now ledipivir was settled with more than 12 years of age group, but we had another study with it was also showing response in more than 3 years of age group. Now they try to look at how does ledipivir and this regimen works when you have comorbidities present, and they felt that the SVR2 did not change. It was just as good as that in children without comorbidities, and 100% it was seen. And what kind of comorbidities you find in children with SCV is largely hematological illnesses which have iron overload. These are the common ones that you see in these patients. Now the second regimen which was then taken up was sofosbuvir and velpatasvir, and this was done in 2 trials which were reported only in the liver meeting in Boston and thereafter. The first study was 173 cases, more than 6 years of age. Regimen was given for 12 weeks in 1, 2, 3, 4, 5. 6 for genotype 6, we did not find any cases in that. 85% of them were treatment naive. SVR was 92%. And regimen used for 213 patients, age group 3 to 17 years of age. Phase 2 trial, SVR again was 92%, with not much serious adverse effect except for one child having auditory hallucination. Treatment discontinuation was present in a very small percentage, and they just said that the authors felt that you should not avoid using it with amiodarone, which can cause some heart dysarrhythmias. So with this study, the FDA approved first this pangenomic regimen. First they took it for patients more than 6 years of age, and then they allowed in 21 to take it for even children more than 3 years of age. But this was only FDA. It hasn't reached the ASLD. The third regimen that we have seen has the GLE and pibrentasvir. 2 studies, DORA-1 and DORA-2. DORA-1 study was largely done in older children, 12 to 18 without cirrhosis. Majority were treatment naive, genotype 1. 8 weeks it was given for some, for 3 patients it was given for 16 weeks. SVR12 was 100%. Even the HIV status improved in these patients, and the mutations of NS3, NS5A did not make any impact on the outcome of these patients. No serious adverse effects, good pharmacokinetics, comparable with adults. This regimen has been demonstrated now to be safe and effective in those with prior exposure of DA and not having improved on those. compensated cirrhosis, severe renal impairment, HIV, co-infection, and liver and kidney transplants also. But here the 5 and 6 was not tested, and it was said that we should extrapolate the data from the adult side. The DORA-2 study then went on to take up 3 more age cohorts, which is 3 to 6 years, 6 to 9 years, and 9 to 12 years. Looked at the pharmacokinetic safety and efficacy. Pharmacokinetics was just as good as that of the adults, and the efficacy was 93 to 96 or 100%. Overall efficacy was 96%. If you look at the pharmacokinetics, it was looked with a dosage ratio of 40 to 40 and 15 milligram, but later on they increased it to 50 and 20 milligram, and the pharmacokinetics were doing well. So this again did very well. Both these DORA-1 and DORA-2 study had very mild to moderate side effects. Availability in the granular form of this regimen was an aid in administration of younger children, and however it is not available in the Indian market. That is the problem that we are facing as of now. The last of the regimens which have been seen only in the Egyptian patients or Egyptian centers have used this regimen is the sofosbuvir and daclatasvir. This was first seen in 2 studies, which is the first study had just 10 consecutive patients and gave response-tailored duration to these patients and showed a very good response. Similarly, they used it in 40 HCV genotype 4 patients, 8 to 18 years of age, and again the SVR12 was almost 97.5%. They have also gone and tested the daclatasvir drug exposure in children who are using adult formulations, and they felt that it is safe to be utilized for even children up till 10 kgs of weight. And seeing this study, the WHO felt that it should be recommended, but FDA did not allow this recommendation. So of now, this again is one table that I have taken from Dr. Ujjwal Podar's paper. I think it has been, it incorporates most of the data that is there up till now. This combination of ledipivir and sofosbuvir can be utilized for all for genotypes 1, 4, 5, and 6 for age group above 3 years of age for 12 weeks, and it's good enough. But for the other 2, regimen, that is sofosbuvir and velpatasvir, as well as glecaprevir and pibrentasvir, these are both regimens which are pan-genomic. They're effective pan-genomic. The first regimen can be given for 12 weeks, the second regimen can be given for 8 weeks, and all these 3 regimens can be utilized on all children above 3 years of age. This is how things stand as of now based on the studies, but not so for the AZLD recommendations. AZLD recommendations, I will not go into details of that, but they still, if you ask me, they're still not very happy, and they're not allowing the velpatasvir and daclatasvir to come through. And so they're still talking in terms of genome. This genome and that genome should be given with this kind of experience and that kind of experience. And I think in confusing that matter at this point is no longer required. What we should be thinking about is this particular 3 regimens which are available. At least 2 of these regimens are available in our country, and we can easily utilize them, and they are showing response. As far as other special scenarios of HCV infection are concerned, acute HCV, we can treat it just as chronic HCV. Co-infection with HIV, give ART, keep an eye on the drug-to-drug interactions, and also irrespective of CD4, and at the same time also give DAAs. Co-infection with HBV, DA can cause reactivation, so monitor the HBV very well during and after the treatment is over. And for HBV treatment, it should be the recommendation that we follow. Allograft recipient, before you know the status of the donor, you can give preemptive and prophylactic DA with pan-genomic regimens. Otherwise, if you know the donor, that donor is HCV positive, then early treatment within first 2 weeks of post-transplant should be with pan-genomic regimens. The research gaps, I conclude with research gaps because we have already concluded in the last 2 slides about how to treat, but I conclude with research gaps. Sofosbuvir and daclatasvir have not been tested in 3 to 5 years and 6 to 11 years of age, and in children under 25 years, and we must try and see their adverse effects, tolerability, and pharmacokinetics. We must also look at the growth effect. DA effect on growth and cognitive function, on educational attainment, and on quality of life among children and adolescents. Cohort studies on DA treatment outcomes in children and adolescents with cirrhosis, maybe decompensated cirrhosis, with previous experience, treatment experience with genotype 3, HIV co-infection, and renal impairment. There are very little data on this, and we need more data on this. And I thank you with this message that national elimination of SCV will not be achieved unless children and adolescents are also tested and treated. Thank you.
Thank you, ma'am. Thanks for the lucid presentation and mentioning about the research gaps. Yet another complicated topic on pediatric cholestasis, progressive familial intrahepatic cholestasis, PFIC and beyond. We would like to invite Dr. Sadhana Lal. From PGI Chandigarh. Over to you, ma'am.
Okay. Good afternoon, everybody. And at the beginning, thank you to INASL for this great event and for me to and allowing me to discuss or rather touch upon the spectrum of PFIC, which is extremely important from the pediatric perspective, but may also be important from the adult perspective. Now, if we look, we have come a long way from 1965 when Clayton gave the first description of PFIC in the form of Byler's disease. The next 2-3 decades were spent in sorting out the clinical, the histologic, biochemical, the phenotype of this disorder, culminating in the discovery of the culprit genes in the late 90s. With the transition from the older, tedious technologies to the high throughput NGS, there has been an explosion of PFIC variants, and you can see from 2014 onwards, nearly every year a new variant is being described. So if you look at this, we have got a number of PFICs labeled from 1, 10 to 10, 11, 12, I don't know how long it is going to go. And each of these disorders is caused by a mutation in a gene which is coding for particular proteins which are either on the canalicular membrane, have something to do with the tight junctions, the trafficking proteins like myo5B, or the regulatory proteins like FXR. In addition, every day new proteins and new mutations are being discovered in exporters such as OST, alpha beta, there is the LSR, USP53, and so on. Now, if we look at the clinical spectrum of the mutations in these perpetrating genes which are responsible for PFIC, we find that it is a disease continuum. From the milder intermittent varieties such as transient neonatal cholestasis and BRIC to the chronic progressive forms such as PFIC, DILI, ICP, etc. lie somewhere in between, and now we clearly recognize that even heterozygotes with these mutations can have chronic liver disease, especially true for ABCB4. So it seems to be senseless to label these disorders or call them by their arbitrarily given numeric names. Better to know them or identify them by the names of their genes. Now, the classic PFIC phenotype is exemplified by this child who came to us at 9 months of age with jaundice, diaper staining, correctable coagulopathy, growth faltering, firm organomegaly, cholestatic profile in the biochemistry, significantly elevated enzymes and bile acids, low GGT, and a high alpha-fetoprotein. Now, this phenotype, the PFIC phenotype, if it is present, and especially if there is either a low or a high GGT, there is a 2/3 likelihood of finding a genetic diagnosis. The problem is that this phenotype is mimicked by a number of genetic disorders.
So in this particular patient, we found a missense mutation, homozygous on ABCB11. Unfortunately for this child, despite a sibling death earlier on, this patient is doing well so far, fingers crossed. Now, second child, similar phenotype exactly. Family history present as in the other child, but the child the elder child in addition had intellectual disability, microcephaly, speech delay, seizures, some deafness. Now, both these brothers were dysmorphic, are dysmorphic rather, co-species, outwardly rotated large ears, you'll see in a minute. Again, cholestatic profiles, but you will note that the enzymes and the bile acid levels are lower than the previous one. And also, unlike the previous child, these brothers refused to respond to any form of pharmacotherapy, had to be subjected to internal biliary diversion. Responded for a while after the diversion, relapsed, and then inexplicably, now they are currently both asymptomatic, and the cholestasis is down to a low with nearly normal LFTs. These are the children currently. The neurologic problems of the elder sibling, however, persist. Both of them homozygous for the same genetic mutation in ATP8B1. Missense mutation with predicted pathogenic potential. Now, this third kid, 8-year-old, when he presented somewhere else, not to our hospital, came with jaundice and with abdominal distension secondary to a splenomegaly. He had normal growth, but high GGT, raised enzymes, had a ceruloplasmin of 14, also had varices. Patient was started on trientine, couldn't bear the cost, so came to me for a second opinion. We told him to bring the biopsy. Biopsy was tiny, but seemed to show some evidence of autoimmunity. We thought maybe overlap. Started him on ADCA, steroids, and azathioprine. Subsequently went on to have a stormy course after an episode of SBP. Recovered, but to our dismay, the enzymes wouldn't budge. GGT remained high, and we did a bile acid at this time, it was high. Did an exome sequencing when we found homozygous variation, missense, potentially pathogenic in ABCB4. Interestingly, sister presented to us this year in January, had been seen by the adult hepatologist earlier, who had labeled and put her on treatment for Wilson's. Father came back to us, and because the younger one was being treated by us, and we obviously did not agree with the diagnosis. Unfortunately, she deteriorated fast, developed very high bilirubin, poor synthetic function, and is up for transplant. In contrast, the sibling with the exact same mutation is doing well. He has nothing but hypersplenism to bother him. So we have an identical genotype but different phenotype. Is it incomplete penetrance, variable expression, or is it being modified by some unknown genetic, epigenetic, environmental, or probably in this case hormonal factor because the girl was pubertal? We don't know. Now, if you want to differentiate the three PFICs, we have to understand that BSEP is the major bile salt transporter. The FIC is responsible for maintaining the integrity of the lipid bilayer and also of the health of the BSEP and the MDR3 exporters. And the MDR3 is responsible for making the bile less detergent by flopping the phospholipids from the inner to the outer lipids to help in micellization. Now, what is the clinical difference? Basically, age is at a later onset in the MDR3 disorders as compared to earlier two. However, the BSEP disorders are the most severe phenotype with severe pruritus, early progress to chronic liver disease, end-stage liver disease, higher enzymes, higher serum bile acids. Obviously, ATP8B1, which is widely expressed, will have extraintestinal manifestations, pancreatitis, hearing loss, diarrhea, etc. has been described. Post-transplant fatty liver and diarrhea also happen here. The GGT is high in MDR3, whereas it is low in the other two. Coming to the histology, it is bland cholestasis in the ATP8B1. The fibrosis is usually lesser, contrasting it to the giant cells in ABCB11, lots of fibrosis and absent or variably expressed BSEP3. The MDR, on the other hand, presents with a distinctive feature of biliary fibrosis in addition to the cholestatic findings. Usually we find copper and we find retention of the BSEP stain, though the MDR is variably absent depending upon the severity of the mutation. Another interesting boy, again initially presented outside, had with recurrent jaundice, abdominal pain, no pruritus, was having significant stunting and portal hypertension, varices when he presented. Now, this child also had a IgG which was elevated and ANA was positive. So, on the basis of the biopsy done outside, which was not available to us, and he also had an MRCP which showed bleeding of the bile ducts. So, he was labeled as autoimmune hepatitis ASC and started on immunosuppression and ASA. Came to us because of lack of response of enzymes. We switched from Visolone to MMF, added ADCA, but the response continued to be dismal. Jaundice progressively increased on our follow-up, no response, and at that point we thought we'd better do a biopsy before it is too late. What we found was biliary fibrosis, exuberant, lots and lots of cholestasis, no evidence of autoimmunity. The MRCP findings remained same. We expected a homozygous ABCB4 mutation. What we found was a heterozygote. Mutation was pathogenic, predicted to be pathogenic. So how do you explain when a heterozygote gets a clinical disease in a known autosomal recessive disorder? It could be a gain of function variant, which is resulting in an altered gene product or expression, which is having a dominant negative effect, which is interfering with the function of the wild gene product. It could be a loss of function variant, which is creating a haploinsufficient state. That is, the product of the normal gene is insufficient to sustain a normal phenotype. It could be a second mutation, a large deletion or a duplication which is not picked up by the NGS, that means inappropriate test used to pick up, or it could simply be a red herring, which is worsening or modifying another disease, say Wilson's or whatever, autoimmune liver disease, much like the heterozygous PIZ, the mutations work in ALD and NAFLD in adults. Now, do carriers of ABCB4 variants put themselves on the highway to liver disease? The elegant GWAS study from Iceland showed clearly that ABCB4 variants are correlated with a wide variety of liver disease up to cirrhosis. And we are well aware that up to 1/3 of patients of ICP and DILI would have heterozygous or sometimes homozygous mutations of ABCB11 and ABCB4, to a lesser extent ATP8B1, and up to 50% of LPAC would have ABCB4 mutations. So what is the status of adults with uncharacterized chronic cholestatic liver disease? Now, there is literature in the form of case studies as well as cohort studies to show that up to 1/3 of these patients also would be either hetero or homozygous for especially ABCB4, but increasingly the other variants are also being described, like this study from King's College, which showed that 28% of their genetically undeciphered chronic cholestatic liver disease had actually variants of these three types. And significant was that 75% of the patients with ABCB4 mutations had chronic liver disease of a severe and early onset, and most of these mutations were loss of function variants. We understand broadly that nonsense variants give rise to protein truncation and poor response to all kinds of therapy, whereas missense mutation can respond to forms of therapy depending upon whether they hit the maturation, the activity, the stability of the protein, or have no effect. But clinically, we know that missense mutations also can cause significant liver disease. So it boils down to the amount of the loss of function. If there is a complete loss of function by the mutations on both alleles, then we'll have a severe phenotype, PFIC, in early childhood. If there is some retention of function, we'll have progressively milder phenotypes. And in the case of BSEP, second hits seem to be important, because if there is a drug injury, or if there is pregnancy, OCP, etc., the function will dip down transiently and then recover. Whereas there is a linear correlation, more or less, in the case of MDR3. Now, this is the last case that I'm going to show. Now, this is a child whom we were sure is PSC. She had dilatation of the biliary tree, she had a high fecal calprotectin and ulcerative colitis-like picture, though she had a very high IgG as well. Biopsy classically showed a chronic cholangiopathy. You can see it here. And the enzymes were high, stayed high. We don't expect too much change on UDC anyway. The exome showed 2 mutations, USP53 as well as MYO5B, both predicted to be pathogenic. So what do we do with such cases? About 60% of the patients in our clinic have got heterozygous mutations with the PFIC phenotype. and this is more so with the newer PFIC variants rather than the older PFIC variants. So this is a major problem. I think everybody would be facing it. So how is causality of newly detected variants determined? It is by in silico analysis, which tells us about the altered protein structure and function. Ideally, there should be an in vitro confirmation of the cellular effects of the mutant protein, but this cannot be done practically because there is a veritable explosion of variants in our face with such a lot of NGS being done. So invariably, the information of pathogenetic potential has to be derived from whatever is there in literature or from in silico analysis. So that gives us the scenario where something which is predicted to be pathogenic today is likely to turn out to be benign tomorrow, or vice versa, as more and more data is added to the various databases. Complex post-translational regulation is necessary for the normal trafficking, localization and function of the various proteins, and understanding all the spokes in the mechanics is very important before you can actually tell whether a predicted pathogenic mutant protein is going to cause disease. So there has to be invariably a close clinico-pathologic, biochemical and genetic correlation. Now coming to TJP2, it is responsible for the correct localization of the claudin-1 in its transmembranous location, and when it is localized, this localization, when it is mutated, this localization doesn't happen, resulting in a defective, I'll take a couple of minutes more, paracellular junction leading to leakage and cholestasis. Now the cholestasis is associated with absent TJP2 on staining, but is variable in clinical presentation. From early infancy right down to adult cases being described, HCC has been described. Earlier it was thought everybody requires transplant, but that is not the case. We've got plenty of cases in our follow-up who have done well on pharmacotherapy, and that is the literature too. FXR mutation obviously is more sinister. It is the key regulator, and once it is mutated, it massively increases the bile acid pool and results in significant hepatic failure, early onset hepatic failure with the cholestasis, with a profound uncorrectable coagulopathy. Now these cases invariably require a transplant, but some of them will not do well on after a transplant and will get steatosis also, which is because of the loss of the FXR activity in the intestine. Now, MYO5B is responsible, this is the last couple of slides left. MYO5B is the protein which is responsible for the correct localization of the BSEP and other transporters to the canalicular membrane, and with the help of RAB11. When there are mutations hitting this complex, there is a phenotype which can be either in the intestine, protracted diarrhea, because it is also expressed there, or isolated liver disease, or a mixture of the two, with the cholestasis happening either before or after the intestinal transplant. Fortunately, the liver disorder is mild in most of these cases. There is a very interesting staining which is there, because the BSEP and the MDR3 do not get properly localized. There is a thickened canalicular staining and a granular subcanalicular area which represents the mutated MYO5B. As I said, the liver phenotypes is not bad. In rare cases, it will be bad, and this is the last slide, actually. So concluding, the PFIC story has evolved thanks to 2 or 3 things. One is that we perfectly understand the mechanisms of bile acid transport and regulation now. We have cheap, high throughput NGS available, and these allow us to investigate and actively search for variants in the pathways of bile acid transport and regulation in cases which have got genetically unexplained PFIC phenotypes, resulting in the discovery of newer cholestasis-associated variants which are predicted. The mutated protein structure gets predicted in silico, and the pathogenicity gets predicted in silico, bioinformatics, in vitro, and we have a whole horde of new PFICs, and the list will keep on growing, I'm sure, this being a typical result of a systems genetic approach which is being followed in many pediatric diseases now. So we need to possibly test those individuals who have got unexplained chronic cholestatic disease, especially if there is a family history positive. But we need to be prudent. We have to be very certain about our clinical phenotypes so that we don't end up with uninterpretable data and do not have to face horrendous issues. Not only is there a problem of how to do genetic counseling in such cases, but it is likely that in the future we'll have a number of serious ethical, legal, and insurance issues which will crop up because of this availability. Thank you for your patient hearing.
Thank you, Sadhna. for a very nice talk, and not just talking about PFIC, but bringing out the difficulties which we are still facing and yet to supposed to be solved. Now I would like to invite Dr. Neelam Mohan. I think all of you know about her. She is going to talk on a very important problem of biliary atresia and how we should go about improving the outcome of this very important entity.
पहले ऑन करना फिर टाइम लगाना Thank you everybody for attending and thanks to all the chairs and INASL for this opportunity. The previous speakers were all very interesting and I had a great time. So the topic is very unique where it's very clear about talking of the outcome. We all know few bits about biliary atresia, but I will emphasize the part which is directly related to the outcome. So it is called as progressive obliterative cholangiopathy. That means it is usually progressive and the earlier you pick up, better it is. And there is damage of the extrahepatic, intrahepatic bile ducts, which leads to cholestasis. We think it is 1 in 10 to 15,000. Exact incidence in India is not known. But there are papers which say that the girls are more often affected than boys. And also there are papers to suggest that it is more in the eastern part of the world, in Japan and China as compared to the West. So the dictum now, there are some changes which I would want to emphasize. Earlier we used to give an algorithm, and even in Indian pediatrics we talked about sick baby, non-sick baby and all that, did a lot of work in trying to come out with these guidelines. But I think I'm very impressed with the USA. Right now what they said is, every child, unless proved otherwise with conjugated hyperbole, rule out biliary atresia. I think this will make life easy because we first want to get biliary atresia out of our mind before working into that. Of course, the smarter you get, you want to separate into sick and non-sick, but this message is generally for pediatricians so that they don't get confused about sickness and not. So we need to suspect it in all patients, in all babies who come with direct hyperbilirubinemia. Why it occurs, we don't know. There is a whole list that we keep talking about, and that is the sad part, because once we understand why it happens, we'll do. So there is so many progressive inflammation, destruction, association with genes, CMV, yes, no, Rio, yes, no, autoimmunity goes on. So the entire focus on the outcome would be how good we are at diagnosing, because this condition treatment is purely surgical. So the outcome is dependent what age you diagnose and what is the type of biliary atresia, what is the age the patient goes for surgery, what was the fibrosis, and who was the surgeon doing it. To elaborate on this, I'll give you some information. Why did I say these facts? So firstly, there is two types of biliary atresia. One where in utero things are starting. So the embryonic variety, because it is starting in utero, you can imagine the baby may be born with extensive fibrosis, though I'm saying it is progressive. But these are only 10 to 20% of the babies. The postnatal form, and that's where the confusion arises, because it's not always the first week, because we have been teaching that it's very early, it starts with it. But if you see literature, they can start, the parents may be able to identify, and the progression happens not necessarily in the first week, but it may be in the second to 4 to 6 to 8 when the patients are identifying these issues. It is very important to understand these types. Why it is important is the outcome of the surgery is very simple based on this anatomy. If the lower green part is the blocked part, in type 1 and 2, you can see the upper part is yellow. So even if you do a surgery, there is patency upper part and the outcome is going to be good. If you do a surgery in the lower part, the type 3 which shows a green totally blocked, in that the outcome is usually not as good as 1 and 2, because in simple words, where you're going to do your hepaticojejunostomy, above it where the ducts are available to secrete it or not. So these are the anomalies that are associated with it, and these anomalies, what we talk about is, suppose cardiac anomalies, etc. So that's why an outcome is also dependent upon what are the other comorbidities, if it is a simple cardiac anomalies, or they could be even significant ones, as I talked about, bilobe, lungs, etc. So the diagnosis in any thing, we always say clinical diagnosis, lab diagnosis. So clinical diagnosis is making things simple. Usually the baby is a full-term baby, growing well, thriving well, drinking well, shitting well, passing urine. So that is how the baby goes unnoticed, because everything about that baby is well. But if you look, it is the urine which is dark, which stains the diaper, and the stools is light colored, and the first time mom may not be able to understand what is light color, because when we say light color, there is a chart which we always talk about, the stool chart, and which the Taiwan group, I guess, came out with. And the beauty of the chart it shows is, what looks yellow to you may not look yellow to the doctor. So the first three things which you looks yellow to the mother is not the real pigmented. And for Indians, it is very easy for me to say, haldi jaisa hai kya? If she understands haldi jaisa nahi hai, then I will assume it is not. But you need to see the stool yourself. And so this is the typical thing: conjugated hyperdark urine, clay stool, coagulopathy which gets corrected with vitamin K, hepatomegaly initially, hepatosplenomegaly if you're seeing a little late case, and if you find ascites, then you've lost, the early age and the patient is already advanced. Now, what is the investigation that I have in my kitty is the bloods, the ultrasound, the HIDA, and the liver biopsy. And you need to be smart when the patient is coming to you and what you want. Bloods, will it help me? Not really, but one thing, gamma GT, if it is less than 150, it is unlikely to be biliary atresia. Most studies have shown that you cannot have low. So that is one thing which can help. And the rest of the thing, it cannot differentiate from the other neonatal hepatitis. Ultrasound, this is the one which we talk about, the triangular, this sign, where you can identify some fibrosis or thickness or a cord site. And yes, it is useful to rule out choledochal cyst and other anomalies, which might help you to decide. You find polysplenia and preduodenal vein, then you know you're dealing with that. And of course, you look at the gallbladder. We try to do it fasting, looking at gallbladder, atrophic, dilated, abnormal, etc. HIDA is useful only if it is excretory, it rules out. If it is not excretory, it may or may not be biliary atresia. And the disadvantage is you need to give 5 days priming with phenobarbital, and some studies said urso, but we still believe in phenobarbital better than that. And biopsy is very informative in good centers, because you identify the bile duct proliferation, bile duct plugs, and the extent of fibrosis that we are talking about. But nothing is 100%. So HIDA is like 50-60%, ultrasound 60-70%, and liver biopsy 95-97%. And ultimately, when it is the intraoperative cholangiogram, but maybe in a decade, I think I would have subjected around less than 5 patients where we could not actually identify early, and we said, yes, it'll be the peroperative. And out of them, 2 were, and the other 3 were progressive. So ultimate final diagnosis is looking at the cholangiogram. And in the cholangiogram, you should see it not only goes into the intestine, but it should go into the liver also. That is the time. So treatment is surgical. Now, depends when you see the patient. If the patient comes to you early, it is Kasai potoenterostomy. if they come advanced, it is liver transplantation. And Kasai is the hepatico-jejunostomy. Most papers say that preferably 60 days, 8 weeks, etc. And I'll take you to that journey, what they mean, and subsequently the typical dialogue, ye dil mange more, you want 3 weeks to 4 weeks there. So earlier papers most suggested this way, that less than 60 days, bile flow is 60 to 80 and 45 to 60. And it also depends on the morphology, where they connected what was the remnant, what was the duct remnant, what was the size that is there, and this is what has been said about. But there was a data which I had actually borrowed from Richa from SGPGI. Not sure whether she published, but she had shared with me. And even if when they did, most of the patients that she had shared data was around 80, 90 days. So she, instead of saying 60, she said, so the outcome was still around 30. And I think even in less than 60, she was not able to say 60 to 80 like this slide says. So this is the French paper which I was wanting to talk about, that less than 30 days, whether it is the USA series, Canada, France and all, they are just trying to talk about that the outcome is even better than what you're thinking for 60 days. And that's why I said Dil Mange More, because instead of saying 2 months, it's time for us to say we want to get the diagnosis by 3 weeks. So that change in the mindset we need. And this is that France paper which is just showing you less than 60 days, the outcome and survival with the native liver. 10 years survival with the native liver was 42%. And then as you see, even with 31 to 40 days, it was there. So there was not significant difference 30 till 45, but once it grew from 45, 60, the native liver came down a bit with that results. So rough outline when we talk to the parents is generally something like this, that 1/3 after Kasai remain asymptomatic, and they are doing well and you don't need transplant. 1/3 are not going to show any response and you need a transplant. And 1/3 may do well initially, but then they progress and eventually they develop cirrhosis and you need a transplant. And if you didn't do anything for this, that's why I said the outcome is surgery, because if you don't do anything, the outcome is the patient you would lose at 1.5 to max 2 years that papers have talked about. So the outcome, this 15 years, this is one paper which comes from India, where they also said that out of the 89 patients that they did, 47% were still alive and the rest died in them who did not go for transplant. And this is talking about the native liver. The cholangiopathy progresses and the complications, portal hypertension, recurrent cholangitis or tumors. This, even post-Kasai, you may progress with this and you would need a transplant. And that French paper talks about the 20-year survival with the native liver was 39% in the first month and then 32%, 28 and 39. As you keep moving on, that's all. So this was one interesting study which we did at our center, where we wanted to look primary liver transplant versus transplant post-Kasai. Was there any different how it is to say? So we took the patients who underwent liver transplant and looked into that data. There were 144 patients. And if I divided them, 65% had actually had a Kasai before. And 35 patients had presented late. That means they were already cirrhotic, ascites, 3 months, 4 months, whatever. They presented late and so without a Kasai. And then that was the group that we had to compare. And you will agree with me that in the group which was with Kasai, the patients who needed, who came for transplant more than 1 year of age were 54%. And the less than 1 year were the ones who I said did not respond. So once there is no response, you will go. So that means we did have a good cohort, like half of them who didn't respond and needed it within a year, and the rest half, right now I don't have the mean or the median. Just I divided them into less than 1 year. But if you had patients who came without a Kansai, predominantly 70% would be younger age. Within a year, they would end up needing, and some of them, maybe as I said, 1.5 years, 2 years is the time when you don't do a surgery, that up to that time came. So beyond doubt, there was statistical difference. If you had a Kasai, then you would come later on. So the age, the mean age when the babies presented was later. The weight that they had was later, because you can see that the mean age was 40 months close to in the Kasai group versus 10 months, and weight was also significant. With that, it's 2 minutes, so I alert, right? So with that, this is the variable. What I'm trying to show here is those babies who had Kasai earlier had higher chance of perforations and biliary complications as compared to those who did not have a surgery, because additions, perforations all are more common after a surgery, and that was the major difference in the biliary vascular perforation, re-exploration, and this. So patients with Kasai had relatively, only significant was the perforation and re-exploration rates that we talk about, and there was no difference much in the other sepsis, acute this, even between the other groups. So the outcome survival was not different. Even in that group, there is an 85 and 86. So though there was more complications and cost and stay was more, but the outcome was not different. So I would just summarize the talk by saying that it is time that we need to understand the early the age of diagnosis, the better is the outcome. So our purpose should be to try to identify them within a month of age. And we've talked about the clinical features, biopsy rates, the best in terms of all the investigations that you have. Ultimately, it will be intraoperative angiogram. Whether these patients should be subjected to primary liver transplant is when you think the patient comes to you in an advanced stage, then it is time that you need to talk to the parents, because A, you've spent on the Kasai, B, you've had more complications. So this is 1:1 discussion with the parents on an individual basis as to what you want. Thank you so much for having me over.
Thank you, Dr. Neelam, for that excellent talk on biliary atresia, how to improve. I think we are running short of time. We'll first open the floor and we'll ask Professor Ibrahim Koshi. Thank you for sitting through. You wanted to ask a question. You forgot.
I thought we are running out of time.
No.
Anyway,
I think we'll ask one question for each.
To Abha. See, below 5 years, you are saying there's a high probability of metabolic liver disease presenting like NAFLD. And you have taken the cutoff for diagnosing NAFLD as 9 years. So there is a gap between 5 and 9 years. So, but why have you fixed 9 years?
Yeah, because that's what the NASPGHAN suggests. And you do see the pediatric fatty liver disease in the older age group. In the older children, you don't see it in the younger ones.
So what she said, she clearly mentioned that 9 years is actually a guideline from America. She said less than 5 years of age, we should think of the secondary cause of fatty liver, which are often the metabolic disorders which she enumerated.
So that is what
And beyond 5, certainly we should think of the fatty liver disease. That's right.
Beyond 5. But I think the majority we do a liver biopsy. So that is
Yes.
You know, this question is usually asked by adult hepatologists. You know, No, I just have, Ujjwala, I want to know from this house, how many of us have had trouble diagnosing NAFLD vis-a-vis inborn error of metabolism? This is just two separate types of patients.
Very rarely, except that one case
Actually,
I think I had.
very
that,
rare.
Very
No,
rare.
so the guidelines have changed. I didn't want to interrupt in that. That now, which is just coming out, and FibroScan is included. The last papers, they have included the FibroScan in that. And also, biopsy, they have reduced a lot. So the new papers which are just...
MRE is as good as a biopsy.
They don't want to do it. They want to see holistically. And of course, there are some cases where you get stuck about
There is a doubt.
biopsies ka guidelines
Dr.
is
Poddar,
different
please.
in NASPGHAN
Yeah.
and ISPGHAN.
Yeah, but the NASPGHAN is not yet included fibroscans or MRI.
Actually, their papers is just about to get published. I mean, that group, so they sent.
Dr. Poddar, you... please.
No, I am just going to address Dr. Koshi's question about why 9 years. 9 years came from a study, autopsy study from USA, where they have done autopsy of all age group of children, more than 200 children, and they showed otherwise healthy, those who died of accident, not because of the disease. There they have shown this NASH is seen predominantly 9 years and above. Less than that, it is extremely uncommon. Less than 3 years, 0%. So that's why this 9 years came, not from any other data.
I just want to take your, Neelam, I want to take your, suggest two papers, very nice papers, come in the last 2 years. One from UK, from Devonport's group, who talks about early cholangitis and how it affects the outcome of biliary atresia. And the second paper, which is even more important, is from George Bezzaro, who was the president ASLD till about a year back or so. And his group has now shown they have fixed a protocol in their center with steroids, with antibiotics, and they have now shown the outcome before and after that protocol, and it has certainly improved. So to talk about biliary atresia without talking about early cholangitis.
I kept those slides after, thank you, because for that, what I wanted to say
that
was...
is now the...
Because it is not still taken a role of steroids by all. It is still very controversial. There are randomized trials.
We have to rake that controversy.
That's right.
We have to keep on raking that controversy.
I personally feel that most randomized control trials did not support the use of steroids.
Lately,
So,
Dr.
therefore, it is too early to just on one paper, because I was also involved in that first when he was doing in Rex guy was doing it there. If you do a meta-analysis and see role of steroids, still the outcome is not whether you should give. It's quite individualized, and they wouldn't.
It is not just steroids. I'm talking of protocols. The importance of protocols you have both steroids as well as early institution of antibiotics.
And also the papers which have been coming now from the Japan and that side, whether you should use parenteral antibiotics over patients who have recurrent cholangitis, because cholangitis gives rise to more fibrosis, and it's a double-edged sword. You will have cholangitis only when there is a flow. And once there is a flow, you get cholangitis, and then when you get cholangitis, you get the fibrosis. So people talk about using long-term steroids, which is 3 months, people say, to 6 months steroids, I'm saying antibiotics. And some papers say that you can even use parenteral antibiotics to reduce the rate of infection.
So the prevention of cholangitis becomes a very important factor in the outcome of biliary atresia in patients.
I did put it in there.
With each cholangitis, there's a damage to the liver.
Absolutely.
That will adversely affect the outcome.
I have one question to Dr. Neelam. Associated CMV infection, whether it affects the outcome?
Not really. When there is a CMV infection that you see most of the time, it's not so... Most of the PCRs, whenever you do, the counts are very less. So that is why the message is almost 20% or so of the biliary atresia may have an associated CMV infection. But the earlier thoughts was CMV responsible for this. But we do see, but less titers.
Thank you very much, all the speakers and all the panelists. Dr. Mahathi, with your permission, we close the session. We close the session because the adults are waiting. Next time they will not otherwise give us the slot. Thank you very much. Thank you.
Thank the chairpersons and the speakers for that wonderful session. We learned a lot. Now, moving on, we are now moving on to the next session. We have three very exciting speakers lined up. This session will be on novel concepts in hepatology. I request our honorable chairpersons, Dr. Abraham Koshi sir, please grace the stage with your presence, sir. Dr. Sunil Jain sir, if you're here. Dr. Madhumita Prem Kumar, Dr. Piyush Ranjan sir, and our very own Sarat Chandra Panigrahi sir. So please grace the stage with your presence. Welcome, chairpersons. The session is yours.
Good evening, everybody. So we have this very important session. We have three very well-recognized speakers, leaders in the field. So for the first talk, I call upon Dr. Patrick Kamath for his talk on assessment of liver performance in cirrhosis, past and future.
Thank you so much. And I was told to focus this talk on liver performance as it relates to liver transplantation. So I have no conflicts. I'd like to acknowledge my colleagues Ray Kim and Alina Allen for some of the slides that I'm using in this presentation. So in this talk, I'll go over the basics of survival models, MELD and its variations, the future, and then maybe some take-home messages. Now, survival models are mathematical models, and they assess mortality risk. Now, in medicine, there are a lot of mathematical models, and typically they've been used to study cell growth, and only more recently, in the past 20, 30 years, we're using it for survival. And mathematical models are not restricted to medicine. You know, the chance of whether there's going to be rain or not is again based on mathematical models, and same thing with economics. There's also a mathematical model to determine penalty kicks. Okay, so here is Messi at a penalty, 90 minutes, so it's an extra time. So he's thinking, is the goalkeeper going to dive left or right? The goalkeeper is wondering, that's Inaki, is he going to kick left or right? So whoever predicts better is going to be the winner. Okay, so this is what the model is based on. 85% of kicks placed within the goal are successful. So if you're a football player, just kick between the posts, good chance you will score. 100% of kicks placed in the upper one-third are successful, but they're also more likely to be missed. So if you get it in the upper one-third, you'll always score a goal. Goalkeepers will dive left or right 94% of the time, and you can see that they typically dive long because only 40% of the time they dive correctly, and they save 25% of shots. So if you stay in the center, it saves 33% of the shots. More goals are scored in the center than on the sides. So the conclusion of this model is goalkeepers should always stay in the center with their arms raised. That's the best way of saving. So if one of you, it's not going to be difficult. You just look at the scores over time, look at each performance, and if you create a model, I think you will be very rich. Now, once you've created a model, you look at discrimination. That's how you determine whether your model is good. Discrimination is ranking patients at risk for mortality. It doesn't tell you when you will die. It just says who will die first, and that's measured by the C statistic. So if the C statistic is 0.8, it means your model will be right 8 out of 10 times. You'll predict who is going to die first. So this is what it's typically used for when we say it's a survival model. So it's useful for populations, useful for organ allocation. Then there's calibration. Calibration is when will patient die. So that is not good for organ allocation, but it's useful for the individual patient. So you use calibration to counsel the family about what needs to be done. So let's go over some examples. So discrimination is, let's say you have the 100-meter race. This is 2012 London Olympics. Who will get the gold? Okay, so you want discrimination. So at the start of the race, it is very difficult to predict who will be the winner. So we know in chronic liver disease, there's no good predictor of death because death is going to occur 30 years later out of multiple problems and maybe predominantly cardiovascular disease. So there's no good predictor who will die in 30 years. But as your liver disease progresses, maybe you get some idea, but these models are not accurate. So there's no good liver-specific predictor of death from compensated cirrhosis. Again, the problem is that they're going to die of cardiovascular disease. But as you start moving forward, as you reach closer to the endpoint, your accuracy starts increasing. So when you start getting decompensated cirrhosis, HVPG, albumin, and MELD scores are predictive of hepatic decompensation. And once you get hepatic decompensation, CTP and MELD scores are predictive of mortality. Models are very accurate at the very, very end. So close to the endpoint, the models get very accurate. But you have to understand, is this a predictive model or a descriptive model? So organ failures describe the dying process. They're not predictive of death. They tell you the patient is dying. So for instance, in this picture here, no one is going to say, I predict Usain Bolt is going to win. The TV commentators are already screaming he's won the gold. So imagine there's one ball left and there's 30 runs left to be scored. Nobody will predict to say that this team is going to lose. You know, you're already saying they've lost. So these are called descriptive models. So they describe, so organ failure scores are better used as descriptive models and they're not really predictive models. Now we go to calibration. Calibration is what is the individual time going to be here. That is very hard to predict, and even with liver disease, it's very hard to predict, to say, okay, you are going to die on the 27th of June and you will die on the 31st of August or something. That's very difficult. All our models are good for is discrimination and calibration when they deal with populations, not with the individual group. The next type of model is a static versus a dynamic model. So static model predicts at a specific time point. So it's usually at the baseline, and there are multiple models which predict at one time point. So typically it's when the patient is first seen or when the patient is admitted. Dynamic models predict over time course and their response to treatment. So we have several of these models which predict over time course, And many of these models are very intuitive. So for instance, the Leal score, if your bilirubin improves, very easy, even without calculating, you're going to say this patient is doing better. And if your bilirubin gets worse, you say this patient is going to do worse. Okay, so the dynamic models are very intuitive, and they may not help you that much in making a decision. You want to make the decision early before you start treatment. Now, the child Turcotte-Pugh score is one of the first scores, and it's an excellent model, but there's a forgotten history here. When the model was created, it was neither Child, nor Turcotte, nor Pugh. The work was by Wants and Payne. This is what they described. Wants was a surgeon, Payne was an endocrinologist. Both of them wrote up this paper on 120 patients with a portocable shunt, and this is what they came up with. They had three groups. They called them Group A, B, and C. And see, look how smart they were at those days, because I think it was Mary Ann Payne. She said muscle wasting is important. And we're coming back to muscle wasting here. So it's really Wants and Payne who first described the model. This was later used by Child was the boss, Turcotte was his resident. They studied it and in the book. So Turcotte actually did all the work. Child was the boss who got the name. So it used to be called the Child score. But then Turcotte got back in when Pugh described this model. And this is the only paper Pugh ever wrote. That's where the prothrombin time came in. Described three groups, CTP class A, B, and C. But the credit really for the CTP score has to go to Roger Williams, who was the senior author, and no one ever knows he's part of the CTP score. So that's the history of the CTP score. So that's again the past. Then that's where MELD came in. So used to predict survival in patients who underwent TIPS, creatinine, bilirubin, INR, and cause of cirrhosis. But later it was going to be used for liver transplant, and we did some calculations and we dropped etiology of cirrhosis. We can talk about that later. So this was initially used for transplant, but then we found that it underestimated mortality in patients with ascites and hyponatremia. So Ray Kim, who was one of our fellows at that time and then became a colleague of mine, and Nora Terrace fellow Scott Biggins, they started working on this, and ultimately this is the paper that came out on the MELD sodium. And notice here, this is really where it, I cannot see the green, but if you look at the lower left corner, when your sodium is low and your MELD score is low, that's when you see the greatest difference. If your sodium is above 140, nothing, but if your MELD score is above 40, then no matter how low your sodium is, it doesn't add much. So it's only when you have a low MELD score, sodium adds on. So then MELD sodium became part of the organ allocation policy, but then again we noticed problems. Women were less likely to get liver transplantation than men, and less likely and had a higher chance of dying on the list. And what was the factors for women? Women are smaller, so they have access only to smaller livers. Men are bigger. Women had less muscle mass or lower creatinine. And men had more hepatocellular carcinoma, and they were getting MELD exception points. So height, MELD exceptions, and creatinine, these were what disadvantaged women. So this is Alina Allen's work. So when Alina looked at this, then shared 35 came on. Shared 35 was that over 35, they had the highest priority. And at shared 35, women were further disadvantaged. So there are a lot of women between 33 and 34, and if they were men with a little more muscle mass, they'd have got one more point. So the question was, if we added just one MELD point, would it improve access to transplantation? So in this mathematical modeling that we did, so look at it in blue and in green, okay? Black is what the actual transplant rate for women is. You can see it's lower than men, quite a bit lower. And if we, so that was observed, blue is expected, that's how much we expected it to be, but it was lower. If we added on 1 point, then women would be fine. But the committee was full of men, and they said, no, we need data before we accept this. So then again, Ray went back to work. And we looked at MELD again, because a lot of things had changed since it was first created in 1999 was when we first put that together. Epidemiology of liver disease had changed. There was less hepatitis C, more alcohol-related liver disease and NAFLD. There were older patients, more comorbidity. Creatinine, there was more kidney disease. You know, when we first created the model, we excluded all patients with chronic kidney disease. So it was only those whom we thought had kidney disease related to the liver. So things had changed then. And of course, we wanted to correct disparity in organ allocation in women. So this is what Ray came up with. He did all the calculations. A brilliant man, is really good at modeling. So this is the new model that was come up. So if you're planning models and you create a new model, everyone is used to 6 to 40. So if you create a new model, you shouldn't have a different numbering system, because then you get confused, patients get confused. So the model was aligned so that the 28 on the new model and the 28 on MELD sodium aligned, and then 75% before and after, and that's how it was created. So the same score is used for both. Only difference is upper limit is 40. So the question is, if you give albumin, will it be a problem? Because low albumin helps. But it probably doesn't make a difference, because the albumin is mostly indicated when creatinine is high, and if the creatinine goes above 2, there's very little effect of albumin. So this has been used for the past 1 month. It has come into effect. What about the future? So in cirrhosis, you get cardiovascular changes, so you get ECG changes, RR interval changes, QTc prolongation. So we created an artificial intelligence model in these patients, and we're hoping this artificial model can be used to determine outcomes. So look here. So cirrhosis gives you a score of 1, and if you don't have cirrhosis, score is 0, and we looked at electrocardiograms. So we use convolutional neural network, 5,000 odd patients with cirrhosis, 20,000 odd patients who are controls. What did we find? Excellent performance in distinguishing patients with cirrhosis and controls. Area under the curve was very good. As your liver disease worsened, the score went up. And if you can see here, when you transplanted them, the score came down. So we think this is a good model, and just a simple ECG may help determine your stage of cirrhosis. So I think that's going to be the future. So my take-home message is, MELD and MELD sodium are validated objective mortality predictors. 3.0 improves model fit, and I think most important, it addresses sex disparity. And the future, we need individualized AI risk models for specific purposes, care optimization, and for better pairing of donor and recipient. Thank you.
We'll take questions at the end.
For the next talk, I call upon Dr. Yogesh Chawla. He'll talk on prevention of further decompensation in cirrhosis.
Thank you very much. Grateful to Dr. S.P. Singh, Ajay, and Manoj for giving me the chance to talk on this very interesting topic. Can I go to the first slide? No, first slide. Back. Yes. So we know that portal hypertension is a consequence of cirrhosis. And because of portal hypertension, in case there is cirrhosis, there is dynamicity into the prognostic stages. And the consequence of cirrhosis, one develops ascites, bleeding varices, hepatic encephalopathy. We all know that there are different stages of cirrhosis. Compensated cirrhosis without clinically significant portal hypertension is when the HVPG is less than 10 millimeters mercury, the elastography, the liver stiffness is less than 20 and platelets are more than 1.5 lakhs, and there are no varices. Advanced compensated cirrhosis liver or CACLD is when the HVPG is more than 10 millimeters mercury, elastography is more than 25, low platelets, and there are esophageal varices. You say that an individual has become decompensated whenever there is overt ascites, overt hepatic encephalopathy, variceal bleed. We don't know whether minimal ascites can be defined as decompensated, minimal hepatic encephalopathy or occult bleed, portal hypertensive gastropathy, but certainly decompensation leads to a higher mortality. So portal hypertension is the driver of first and further decompensation. And this, on the setting of portal hypertension, could lead to decompensation if there are bacterial infections, which are very common in cirrhotics because of the immune deficiency. There is superimposed liver damage by alcoholic hepatitis, viral hepatitis, drug-induced liver injury, and HCC and surgery. But here I would like to draw your attention to a new terminology which we all come across in clinical practice, but has been introduced in Bovino recently, and that is recompensation. You define recompensation when you can suppress or remove the primary etiology of cirrhosis. You get resolution of ascites, patient is off diuretics, off lactulose and rifaximin, doesn't develop encephalopathy, has absence of recurrent variceal bleed for a period of 12 months, and there is an improvement in MELD of less than 10 and CTP is 5. So this is what is recompensation, which we should all know. And there is also a terminology known as re-decompensation, where a recompensated person becomes decompensated because of different precipitants. The third new development by the Bovino was the further decompensation. These patients have a higher mortality, and by this I mean further decompensation. Patient is already decompensated. And then the person develops either recurrent variceal bleeding or develops recurrent ascites or refractory ascites, has recurrent hepatic encephalopathy, develops SBP or hepatorenal syndrome. And if the patient has had bleeding alone as a cause of decompensation, after recovery, when the person develops ascites, hepatic encephalopathy or jaundice, this is known as further decompensation. So how can you prevent further decompensation? This definitely could be because of liver transplantation. Most of the decompensated patients, we ultimately plan for a liver transplantation. But if the patient has recurrent ascites requiring large volume paracentesis more than 3 times in a year, with or without a bleed, one could prevent it with the help of tips. If the patient has ascites and low risk varices with no cherry red spots and no child's puke score C, then you should give non-selective beta blockers and preferably carvedilol, because it further brings down the portal pressure. And if there is ascites and high risk varices, then and if the patient is child puke C, then you should be guarded in giving beta blockers, but certainly it is better than variceal ligation. If the patient has tense ascites, if he has decreased blood pressure of less than 90, decreased MAP of less than 65, or has HRS AKI, you should not give beta blockers and restart only if you have improved these conditions. And if the patient is intolerant to beta blockers, then EVL needs to be done in these patients. So this is an interesting study which recently got published where I'll just come to that. You can prevent recurrent bleed with variceal hemorrhage with beta blockers and EVL, and tips if it is required. If someone is intolerant to beta blockers and EVL, one should consider tips, and if there is recurrent ascites, do tips. Portal hypertensive gastropathy again is a gray zone. You should identify it differently from GAVE. And if it is so, then one should give beta blockers But if transfusion is required repeatedly because of portal hypertensive gastropathy blood loss, in spite of beta blockers, then TIPS may have to be introduced. You should prevent infections in decompensated cirrhosis because that's likely to develop spontaneous bacterial peritonitis and other conditions. So you should rule out bacterial infections by doing parasynthesis, different cultures, and treat with antibiotics with as early as possible. And if there is no response, consider viral or fungal infections. And spontaneous bacterial infection and other infections should be avoided because portal hypertension is the driver, and if there is associated infection, then certainly these infections tend to occur in these patients. There is some role of sarcopenia and frailty, and both impact survival, some role in further decompensation. And studies have shown that when you give a high protein diet with exercise, with branch-chain amino acids, especially leucine, it has been shown to improve sarcopenia, frailty, and albumin levels. So while these patients are decompensated, although it's extremely difficult to make them do exercise, but if at all we can do that under guidance, then possibly there may be some improvement. And TIPS has been shown to improve sarcopenia. So this study is what I was talking about, 622 decompensated cirrhotics. They had grade 2 ascites, 52%, and grade 3, that means tense ascites, 48%. Most of these patients were given beta blockers, 37% in grade 2 and 31% grade 3, and all of them were on diuretics. And when there was a follow-up of 49 months in them, 56% of these patients developed further decompensation. And this was in the form of refractory ascites, hepatic encephalopathy, SBP, HRS-AKI, hyponatremia. ACLF also was detected in 25% of cases. Some of them developed HCC. So these patients, while on the management, 13% had TIPS, liver transplantation 16%, death happened in 42%, and 27% had more than 2 events of decompensation. So the conclusion they drew was anyone with grade 2 ascites decompensation with a MELD of more than 15 has a poor prognosis, and grade 3 ascites, any type of MELD would have a poor prognosis. So one should try to treat the etiology, give them long-term albumin, possibly plan for a TIPS or a liver transplantation, ideally. Another study, a study which has told us about the natural history of grade 1 ascites, which is detected on ultrasound only, found that the 1-year survival of grade 1 is about 88% versus 25% if they have grade 2 or 3, which means it is not very necessary that all these patients of grade 1 ascites would definitely go into grade 2 and 3. There are some other factors which we are not very definitely sure about. Yet another study on TIPS in refractory ascites and bleed. There are about 12 controlled studies, retrospective ones, where they found that on a 2-year follow-up after TIPS, further decompensation significantly decreased in these groups of patients, so also mortality. And the 2-year survival was better in TIPS. So refractory ascites is one of the problems in further decompensation. Why does it happen? We are not very sure. The mechanics of refractory ascites possibly is related to the progress of cirrhosis or neurohormonal disturbances which tend to occur in these patients, or possibly cirrhotic cardiomyopathy, which is not very well studied in this group of patients. Same is true for hepatic encephalopathy. Again, more amount of fibrosis, multifactorial. So this could be another reason of further decompensation. Same is true for dilutional hyponatremia, that this happens more because of diuretics, but also it can happen in those where there is compensatory ADH secreted, and this decreases the free water excretion, and that is why there is dilutional hyponatremia. Rebleed in further decompensation may also occur if the portal venous velocity decreases over the time, child's puke score worsens, thrombocytopenia occurs, or if there is a large varicose size. So, apart from two definitive things like liver transplantation, TIPS, possibility of beta blockers, we don't have very many things to offer, or they have not been studied extensively to prevent further decompensation. But taking a corollary from preventing first decompensation, I would just take you through the studies which have prevented the development of decompensation. Agreed that it is not the same from compensated to decompensation you prevent, but since there is not enough study, I will just try to extrapolate. For HCV, when you look at the delisting studies from transplant, 75 decompensated patients who were given DAA, 25% got delisted. Another study again, 130 decompensated cirrhotics, SVR improved the child's puke score, MELD, and the 3-year survival. Again, a big study, and so much so because of the DAA, delisting has happened to a large extent, and HCV is no more the primary diagnosis for liver transplant. Same is true for hepatitis B decompensated cirrhotics, and studies have shown that 1/3 of the patients get delisted. Alcohol, decompensated cirrhosis, again about 8.6% from one of the studies, there was delisting in decompensated cirrhotics. And this they attributed only in the group of patients who had a lower MELD, less than 20, or had an albumin of more than 3.2 and higher platelets, of course with abstinence being there. So what are the other ways apart from treating the etiology? Non-selective beta blockers, if you can bring down the portal pressure, better so with carvedilol, you can decrease the chances of further decompensation, but you have to be careful while giving propranolol and carvedilol because you might precipitate hepatorenal syndrome in these cases. But you have an added advantage. You decrease the GI permeability, decrease the bacterial translocation, and studies have shown that beta blockers decrease the risk of bacterial infection. And this excellent study on prevention of decompensation of cirrhosis in 201 compensated cirrhotic patients on a follow-up of 37 months, when they were given beta blockers, they showed a decreased risk of decompensation and bleeding risk. And some other meta-analyses have shown that carvedilol is better than propranolol in patients with raised HVPG and in those who have compensated cirrhosis. There is some emerging evidence for prevention of decompensation with statins, although in the decompensated state, we would have to be very careful because of the risk of rhabdomyolysis. There are no studies to prevent further decompensation, but this is one of the drugs which has been used for preventing decompensation from compensated cirrhosis. Rifaximin has been found to be of benefit because it has shown that it decreases further decompensation from retrospective studies, and they have shown that it decreases the ascites exacerbation, varicose bleed, and when it is combined with propranolol, it decreases the portal pressure. Although there are not very many prospective studies, but this is one of the important preventive aspects. Anticoagulants, they have been used in compensated cirrhotics to prevent decompensation. There's only one study, but there are a lot of rat models. And then as an extrapolation, DOACs are safe in child's puke B. No information on C, probably they are contraindicated, but we cannot give it as a recommendation. Albumin has been studied again, because if you give, at least from the ANSWER trial, it has been shown that 40 grams twice weekly of albumin and then 40 grams weekly significantly decrease the risk of refractory ascites, SBP, HRS, hepatic encephalopathy, and hospitalization, and improve the survival. And possibly there is a role of zinc therapy also in these patients. So friends, in conclusion, I would say that further decompensation is something what we always see in clinical practice, but it's a new terminology and we all need to think about it. It is associated with recurrent bleeding, refractory ascites, SBP, hyponatremia, and recurrent hepatic encephalopathy, which may occur in this group of patients. Associated with increased mortality, we should ideally treat these patients to prevent further decompensation by treating the etiology, give them beta blockers very cautiously, preferably propranolol rather than carvedilol. Albumin infusions may need to be given to these patients if transplant is not possible. Tips may have to be given to patients with recurrent bleed or refractory ascites if that has happened. Statins and anticoagulants are just conjectural drugs, which studies need to prove that they would be helpful in preventing decompensation. So thank you very much for your attention.
Thank you, Dr. Chawla. We'll now invite the next speaker. The questions will be at the end. Dr. Raj Reddy on healthcare utilization and outcomes of liver transplantation for critically ill cirrhosis. Professor Raj Reddy, please.
Can you go back one slide? Can you go back one slide? Yeah, all right, good. All right, thanks. I've been charged with the task of addressing outcomes following liver transplantation in the critically ill patient with cirrhosis, and as to what it takes to get a cirrhotic to be alive after liver transplantation when they're very sick. So to set the stage, we all are familiar with the course of chronic liver disease in that these patients can go on to progressive liver failure, either as a natural history of cirrhosis, or they can develop what we now know as ACLF. There's a precipitating event such as alcohol use, infection, viral hepatitis, etc. And then once they go on to organ failure, then obviously you're trying to see if they can be brought back through supportive measures, or if they are progressively getting sick, whether they need to be considered for liver transplantation. And then not everyone is a candidate for liver transplantation, and we need to then think of certain futility criteria that would say, hey, listen, transplantation is not ideal here, and that these patients should be provided comfort care. So let's examine the data on outcomes following liver transplantation, but first let's look at waitlist mortality in patients who have ACLF. And this is based on INASL criteria, and this was from the UNOS database from 2005 to 2016. The late Vinay Sundaram spent quite a bit of time studying the outcomes both on waitlist and following transplantation in those with ACLF. I, however, would like you all to recognize that UNOS does not have precise ACLF INASL criteria, so there's a lot of extrapolation. In fact, when my colleague Nadeem looked at some of the cases listed for transplant and they were assessed as ACLF, they actually had progressive cirrhosis. So you would have to take this data with a pinch of salt. And that's why there's a lot of controversy about whether we should be giving MELD exception points or priority for ACLF for liver transplantation. So regardless, if you, and this is no-brainer, if you look at the orange line, that is ACLF grade 3, the mortality is much higher in them compared to those who do not have ACLF, which is the blue interrupted line, and in between you have ACLF grade 1 and ACLF 2. Now then, if you look at post-transplant outcomes, and particularly mechanical ventilation, if you look at those who were transplanted while they were on mechanical ventilation, clearly they had much lower survival at 1 year compared to those who are not mechanically ventilated. On the other side, if you were to look at outcomes at 1 year post-transplant based on ACLF grades, 1, 2, and 3, and mechanical ventilation at transplantation, clearly, if you look at the orange line, that's ACLF grade 3, and they had the lower survival. So mechanical ventilation at the time of transplantation is not something that you'd like to have, as they have poor outcomes post-transplant. Now, then, if you were to look at outcomes based on futility score and ACLF3, look at post-transplant survival probability, you'll see that those who had a futility score of greater than 8, and the criteria are ventilator support, age, hemodialysis, diabetes, etc., they had lower survival. And then if you were to look at those who are on pressors, and had ACLF grade 3, again, you look at the orange line, they had lower survival. So ventilator support, pressors, high futility score, they add up and they don't do well. And then our colleagues looked at transplant by status at the time of transplant, whether they're called in from home, or hospitalized and had a transplant, or they were in the ICU and were transplanted. And you look at mortality, 3 months, 6 months, 12 months. And if you were to look at ICU patients at 12 months, there was about a 23% mortality. That means that there was a 77% survival. If UNOS were to look at our center experience, and at 1 year you had 77% survival, 23% or 24% mortality, our program will be dinged. There'll be a flag raised, and immediately it will be put on probation, and they'll come and audit our program. So we can't afford to have suboptimal outcomes. In a place where there's no accountability, I suppose, you could do whatever you want, but if there is accountability, then we obviously can't take many chances. So then there is survival, mortality, and then there are some other issues that we also need to look at. So if you were to look at acute cellular rejection, which I'm not sure why that would be, but those patients who were transplanted with ACLF3, they had a greater rate of acute cellular rejection, but that we can manage. Bacterial infection, higher rate when they're transplanted with, and this is within 1 year of transplantation in those who had ACLF3. What is more important is dialysis dependence, higher in those who were transplanted with ACLF grade 3. So suboptimal outcome, then greater support needed post-transplant with a greater, higher grade of ACLF. And if you were to look at site of bacterial infections, patients transplanted with different ACLF severities, pneumonia, as noted by the green area, is much more common in those who are transplanted for ACLF3. They probably went into transplant with some sort of pulmonary compromise. Resource utilization, which is critical. Look at length of hospital stay, longer in those who are transplanted for ACLF grade 3, length of ICU stay, not much, length of dialysis during hospitalization, longer in those who are transplanted with ACLF grade 3, and then 30-day readmission rate higher in those who are transplanted with ACLF grade 3. And last but not least, I don't see this data in any presentation of ACLF and transplantation. You never see that. No one talks about it. With increasing grade of ACLF, there are more costs. You can see that it's about $250,000 if you transplant someone with ACLF3 relative to these. So this is something that we also are judged by as to how much we're spending for transplant. And someone is paying, I suppose that's a different story, but we're judged by the amount of money we spend for transplant. So this is just not North American experience. There is European experience. Again, it's often not talked about. This one publication, if you look at ICU length of stay, statistically significant in those with ACLF. Hospital length of stay, statistically significantly longer in those with ACLF compared to those without ACLF. Now let's look at various grades of ACLF. With similar donor risk index, I mean, donors were all similar. ICU length of stay, more with ACLF grade 3. Hospital length of stay, longer with, in those with grade 3 ACLF and had transplant, and those were all statistically significant. Now, this is another publication looking at post-liver transplant complications in those with ACLF. And this is again looked at by the various grades of ACLF. If you were to look at post-liver transplant ICU stay, longer with ACLF grade 3, post-liver transplant hospital stay, longer, and then if you were to look at various complications, neurological, cardiovascular, pulmonary complications, renal complications, etc., there are more in those with ACLF3 who underwent liver transplant, and there are asterisks there which tell you as to which were statistically significant. Extracorporeal liver assist device. There's a lot of talk about it, particularly in India. There's talk about plasmapheresis. And then there are various other modalities, CRRT, albumin dialysis, dialive, artificial devices, hybrid devices, etc. And these are, by the way, not inexpensive. They are very expensive. Now, you heard Rajiv present his data with dialive and talked about his recent publication in Journal of Hepatology. And it makes sense. It's a novel extracorporeal liver assist device. And it essentially removes biomarkers of systemic inflammation, cell death, and et cetera. But if you look at the paper, the 28-day mortality was no different than those who are on dialive versus those who did not receive it. If mortality is a key endpoint, of course, this device removed a lot of these inflammatory biomarkers, but mortality was similar. So again, an FDA or any regulatory agency is going to look hard at the hard endpoint of mortality before they approve such devices for use in certain conditions, including ACLF. Now, this is a paper that Anand Kulkarni published from his center looking at plasmapheresis. Granted, this was not a randomized trial. I know there's a lot of plasmapheresis that is used. This is in the context of living donor liver transplantation for ACLF. And there were 73 patients, and 55 underwent living donor liver transplantation. Time to transplant, it was 10 to 120 days. Those who did not have plasmapheresis and went to a transplant, on an average time to transplant was 45 days. The survival was 71%. Those who had plasmapheresis and had transplant, their survival was 74%. 71, 70. Granted, this was not a randomized, properly done study. But what I was intrigued, and again, you'll appreciate this more than I, an average median amount of 8 lakhs was spent to stabilize, quote unquote, the patient prior to transplant. And some, at the extreme end, it was like 43 lakhs. Well, that's not a trivial amount of money, I would think. So if you really want to know if plasmapheresis works or not, you need to do a proper, large, randomized trial to see if it's actually beneficial or not. There are futility scores out there, and we need to think about futility. Futility is defined as a post-liver transplant survival of less than 3 months or in-hospital mortality, and then the various predictors of futility, multiple organ failures based on CLIF-C score, ventilation, MEL sodium, etc. And then some may have a greater weight than other, and these are dynamic. They keep changing. So you need to really think about futility criteria when you consider transplantation in these very sick patients. So there is a golden window where you can transplant them when there is minimal vasopressor support, there's no mechanical ventilation, they're stable, and of course this can change, and then as I pointed out, you really need to try and take into consideration the variety of futility criteria when you're assessing a patient for liver transplantation. To summarize, advanced and decompensated cirrhosis, or ACLF, is a challenging, these are challenging conditions in the context of liver transplantation. The sicker the patient, the greater the resource utilization following liver transplantation. The increasing number of ACLF-related organ failures has diminishing return, both in survival and morbidity. Longer hospital stay, ICU stay, more comorbidities, higher cost. Liver transplantation is a viable option in select candidates, so you really need to follow the golden window principle. Futility rules need to be kept in mind. My mantra is MELD organ failure trumps surgical skills. The surgeon can say, I can put in an organ in 2 hours, but it doesn't matter. The protoplasm matters. And not every person should have a transplant. You know, unfortunately, we'll have to make some decisions. And we'll need to invoke the futility rule in certain cases where patients are sick with multi-organ failure. And we do that all the time. It is palliative transplant hepatology that we need to practice at times. So with that, I'll end, and thank you very much for your attention.
Thank you. We'll now open it for questions, but I have first a question to Patrick. That last part which you showed on the ECG, some parameter in the ECG which might subsequently be included, you know, to predict survival. I didn't understand. What exactly within the ECG is that?
So first, I think I have to join the opposition. I have to cross the floor. So we don't know. So that is one of the things of neural networks. It gives you something. So to know whether it's the P wave, is it the Q wave, is it the RR interval, what you do is it's called silencing. So just block off the P wave, and then look at the model, then block off the R wave, so that ultimately you can explain things. Eventually we will do that. Remember, this is done on patients who are waiting transplant. We've got a paper coming out. If we look 5 years into patients who are not diagnosed with cirrhosis, we can predict who will get cirrhosis in 5 years. But that's all within our data. We are validating it from a large database in Spain. Once we think it's very good, then we'll try and explain aspects of it. If it doesn't work out, it's a lot of work. It's really a lot of work to figure that out.
Yeah, basically what you're saying is the artificial intelligence has picked up something in the ECG. We still don't know what exactly within the ECG that the artificial intelligence has picked up. Okay.
And in fact, it is so good. From the ECG will tell you 95% of the time correctly whether it's male or female and age within 5 years. What it is seeing, we have absolutely no idea, but it will tell you that.
Sir, another question to you. MELD sodium is the dynamic score. So what is the best time to measure MELD sodium? Suppose a patient with ascites who is on diuretics comes with hyponatremia, raised creatinine. So you will wait for 2 days and you'll take that as the baseline MELD score, or at the time of admission? And what is the period of time for which this MELD remains valid for prediction of mortality?
Yes, so the question here is how often or when should this be scored? So if you go back, when we first developed the score, we were extremely strict. All patients had to be stable, all infection had to be controlled, we had made sure they were adequately hydrated. Anyone we thought had chronic kidney disease was excluded, and so the model was developed on very stable patients. And the long-term validation has been on that. Subsequently, it has not been validated. The sodium has been taken for any time between the previous 30 days. That was what was developed. So the next thing is what is called the delta MELD, the change in MELD over a short period of time. Delta MELD is predictive of mortality only between 4 and 14 days. Beyond that, it's not very effective. and what we call baseline MELD. So whatever MELD you take, that's okay. It is going to change there. You know, the creatinine is going to change when you hydrate. So you work with what you have, but in general, the more stable the patient is, the more accurate your predictive value.
Subrat had a question.
Yeah, open it. Please use the microphone.
I have a question to Patrick. Why did you choose ECG out of all these things? Why not EEG? Why not EMG?
So the question is, why did we choose
ECG?
So we've got a very good cardiology group. They did EKGs, and they can predict cardiomyopathy in 5 years. EKGs in pregnancy can predict postpartum cardiomyopathy. Okay, so that is the breakdown, because you try and work with what you have easily. So we know there's RR interval variation, we know. So the question is, will the EKG do that? We already have a technique, dump the data on them. If they said no, we'll move on to some other person.
So you decided there is a discriminant model in other disease.
Correct.
Let me see whether this discriminant model in my disease is working or not.
Yeah.
That's it.
That's what we did. And my suggestion to all of you is you all have IITs all over. IITs have interest. Try and match your interest with IIT's interest. You'll come up with good stuff.
Wow. That's good. I have another small question.
Yeah.
I think you saw, the ASLD, or even you suggested MELD is dynamic. MELD sodium is dynamic. Higher the MELD, repeat the MELD more frequently. And higher the MELD, do it weekly. Lower the MELD, do it, say, monthly or 3 monthly. But it's a dynamic model that we have seen in many of the conditions. So I don't think any static value of the MELD in a decompensated cirrhosis is valid at that moment because you are intervening. So
yeah, I think we accept that, isn't it?
That's what is.
Yeah, dynamic is better. Yes.
And I have one question to Yogesh. Preventing decompensation, the factors we know are etiology. If the etiology persists, obviously you would treat at that as you have seen. But if you see holistic studies from old studies from DMECO and others, you see the decompensation rate, depending upon from the time of presentation, is varied. It varies from 4 to about 10-11% annually, or progression rate. How do you identify these factors which are associated with progression? And then only we can devise the intervention, because the rest of the things are a standard treatment at different times. So what will be that predictive factor for progression which you can intervene? Do you know that? Patrick or Yogesh or Professor Reddy or Dr. Kosi? Because that's what I see myself.
Dr. Chawla, you want to answer? Can you?
Yeah. You know, one of the modalities that is helpful is the transient elastography. Higher the value, more are the chances.
Individual factors which predict, that's what he's asking.
Right. Immediate.
We don't have clear answers. Is that your answer?
Immediate, we
don't have
predict.
clear answers.
We cannot predict.
Dr. Paulo.
Thank you very much for your brilliant presentation. I have a complex question on the ground of definitions of decompensation, because it is a matter of fact that the 3 biggest prospective studies performed in cirrhotic patients are based on a new definition, that is acute decompensation. In the definition of acute decompensation, the word acute is repeated 5 times. So, in 2/3 of patients who develop acute decompensation, we can put it under the umbrella of further decompensation because it occurred in patients already decompensated. But in 1/3, it occurred in patients with compensated cirrhosis. And the most frequent decompensating event in ascites. But ascites may appear in a progressive, non-acute pathway. So is it time to consider a new definition that is non-acute decompensation as first decompensating event? This is my question.
But there has been a debate on this. Acute decompensation may be attributing to further decompensation. This debate is definitely there. But whether it occurs with time, it would definitely occur depending on the precipitating agents that precipitate decompensation further.
Yogesh, I want to ask Paulo interesting question. What is acute decompensation? Acute or chronic is related to time. If Patrick gives a talk, he will start with a timing. Now a patient who is, he is rightly said, already compensated and you know, or a patient has first time presented with ascites, right? And within say 4 days or 7 days, and then you found he has underlying cirrhosis. In a short period of time, we say it is acute decompensation.
Do you have a definition for acute? Do you have so many days? Or?
No,
this is a clinical term.
There is no...
Because in the canonic trial, if you see acute decompensation, is defined any patient admission with hepatic encephalopathy, any patient admitted with ascites, or any patient admitted with SBP are considered as acute decompensation.
So Subrat, I don't have an answer, I have an opinion. So people say World War III will be fought over water. I think World War III will be fought over definition of ACLF. Okay, because that is the, so I'm very practical and I tell my fellows, they say, is this acute this? I say, I don't care what you call it. What are you going to do about it? How are you going to treat the patient? Right now, I don't see how these definitions help me decide what to do about the specific patient. So I'm very practical. I'm going to treat the patient. Definitions are important for studies, for inclusion criteria, but in the day-to-day management, I don't really worry what I call them.
Next person. I think we should allow the next person to.
Yeah, but there is a great difference in the management of a patient with ascites in the setting of non-acute decompensation. This patient does not require hospitalization at all. If we have millions of this type of patient managed outside the hospital. And a part of the definition of acute decompensation is that all these patients were hospitalized. So there is a difference in the management, you know, between a patient with acute decompensation and a patient with non-acute decompensation.
Yeah, I think this controversy can go on. The next person.
I guess just the thing is, I guess prognostically might be also different, right? So acute decompensation, someone with alcoholic hepatitis, potentially with the reversibility of alcoholic hepatitis, they could do well. Whereas someone who has got chronic evolution of ascites, that tells me that they have quite significant chronic portal hypertension, and that's the kind of patient that I would more readily send them to transplant, even if the MELD is relatively low. Yeah, that's one way of looking at it, I suppose, prognostically. But I agree with Patrick that management-wise, you wouldn't do anything different.
Yeah.
Thank you,
again,
sir.
it depends. We're not hospitalizing them, so we don't hospitalize for ascites, because when I looked at the acute decompensation lot, we don't hospitalize for ascites. I mean, they're hospitalized for typically the other problem. If they've got infection, we'll hospitalize them. If they've got encephalopathy. So that hospitalization part may vary from country to country. That paper that you showed, Raj, 41 days for transplant, the European study, without ACLF, that's because you allowed hospitalization and they don't pay. Did you notice the ICU stay that is way, way higher than in the US? So hospitalization practices are different from countries, so we cannot use that as a criteria.
Thank you, sir. I'm asking Dr. Chawla, sir. Sir, what is the role of statin in presence of cirrhosis with sarcopenia? As you are telling, there is a co-remark on statin. Second, acute decompensation on re-decompensated patient. Suppose they develop acute portal vein thrombosis. What is the status of giving low molecular heparin?
See, low molecular weight heparin or DOACs can be safely given to child's B cirrhotics, not in child C cirrhotics. The chances of bleed are not much in these group of patients unless the patient is in child C. So that answers your second question. And the first one was...
Statin.
Statins.
With sarcopenia, in a cirrhotic with sarcopenia, he is asking.
Yeah.
Is it different in sarcopenia or
No,
non-sarcopenia?
it is not different. Studies are there in compensated cirrhosis. They've given statins, decompensation is prevented. So I just mentioned that this can be a possibility in giving decompensated patients to prevent further decompensation.
Basically, you are saying statin is safe in cirrhosis.
Yeah, no. Same as in...
No. So cirrhosis, there is cirrhosis and cirrhosis. So as part of the European study that was done in Raj, that was the one that was presented. So I'm part of that study. So statins, simvastatin 20 and 40 was used in patients with cirrhosis who are decompensated, and 40 was associated with muscle involvement. So that's the basis for saying only 20 can be used. So I think we have to be a little careful with statins, and also there's a genetic predisposition to who's going to get muscle injury. So compensated cirrhosis, you can feel free to use it, it's not a problem at all. Decompensated, I don't think there's a lot of experience with that.
And it's a safety issue. So even in compensated cirrhosis, if you look at the data, primarily cross-sectional retrospective studies based on, and in fact my colleague published from the VA, statin exposure and the duration of statin exposure correlated with rates of ACLF. Statin exposure and longer statin exposure, the low rates of, but that's not a scientific way of looking at things, and that should not really lead to change in clinical practice. In the US, there are at least 2 studies that are going on now, one at the VA hospital and one the NIH is planning through the Liver Cirrhosis Network prospective study with use of statin. So I think I would be careful about making statin as a standard of care in compensated cirrhosis at this stage. So I just want to make sure, did you mean low molecular weight heparin or DOACs in more advanced cirrhosis? Because DOACs, there's no safety data in advanced cirrhosis, but low molecular weight heparin, I think, can be used, yes. Yeah.
But DOACs have been reported to be used in child's B.
But child's, yeah.
Not in
C.
Another one, sir, what we commonly we are facing day to day. Young man presented with ACLF, where acute cause is alcohol, and subsequently he decompensated with the GI bleed, improved with therapy, endotherapy, and symptomatic therapy. For day of presentation to till 15 years, still he is surviving. Now he has presented multiple times with child C cirrhosis, decompensated in the form of ascites, coagulopathy, GI bleed. Got treatment as accordingly, but still is surviving 15 years. Now how you will define acute decompensation, compensated, again decompensated, how you will end? Still he is surviving more than 15 years.
Did he stop alcohol or continue alcohol?
He stopped in between.
In between.
Once he disease, he stopped. Once he improved, it again started.
So that's called compensation.
Okay.
Again, it does not matter what we call it. You know, it's what you're going to do to the patient. Personally, I don't think we should get too worried about what we're going to call this. It's how we treat the patient that's important.
Thank you.
Sorry.
Yeah.
What's the
One
role of-
last question. Yes.
What's the role of preemptive tips in patients with ACLF who have recently bled? Preemptive tips. Preemptive tips
for
in patients with
for ACLF.
Yes, who have recently bled and who have got ascites. Say child C class.
Don't bleed. Just ACLF.
ACLF, those who have recently bled.
Bled.
Got
Recently
child C.
meaning?
Few days ago.
Few days ago.
The data is not based on ACLF. The data that's out there is based on CPT score. So B, early C, is something that you can consider preemptive tips after a bleed. When you say preemptive, it's after bleed to prevent a second bleed.
Yeah.
But I am not aware of data that has looked at the role of preemptive tips based on ACLF criteria. Are you familiar with that?
Yes, so...
Data from European guidelines.
Pardon me?
EASL guidelines, some of the EASL guidelines.
No, so what was done is in those patients who had bled and had a TIPS within 72 hours, they had a less risk of ACLF. And then when you looked back, many of them fulfilled ACLF criteria. So I think if you do TIPS, you're doing the TIPS for the bleed and to prevent rebleeding. Once you prevent rebleeding, you're also going to decrease the risk of ACLF. So that is what you're actually doing.
Yeah, thank you.
Okay, we'll close. Thank you very much. Excellent talks, all three. Thanks.